Welcome to On Becoming a Healer. I'm Saul Wiener, and my co-host is Stefan Kertész, and today he's actually also our guest. Not long ago, Stefan suggested to me that we do an episode on addiction as a brain disease. As many of you are aware, Stefan is a board-certified addiction medicine specialist in addition to being a generalist physician. And when he initially proposed this idea, I was puzzled. I didn't even know what he was talking about. I wasn't aware there was any kind of debate. I wasn't aware why it was relevant to the general themes of becoming a healer. And then as I started to think about it, I thought it would be unkind and possibly worse to think of it as, somehow voluntary or whatever it is we would say it is if it isn't a disease. But then as I started to look into this topic a little bit more, I realized it's a more complex and nuanced set of issues. It has broad implications for just how we think as physicians and healthcare professionals. And I also started to realize that both the term addiction as a brain disease and addiction as something that's voluntary or whatever else we want to call it, both are in their own ways loaded. They're not neutral terms. Neither is a neutral term. Now, one thing that's interesting is that, and again, Stefan can talk more about this, but from what I can tell, the two sides of this debate actually aren't arguing that much about what's happening in the brain. There is a lot of research on what addiction looks like in the brain, whether you're trying to understand it from a biochemical standpoint or looking at it using functional MRI. The top people on the addiction as a brain disease side and whatever else we're going to call it on the other side are actually in pretty much agree for the most part on what's happening inside our skull. But they disagree substantially on how to interpret it and what that means. And so that's what we're going to talk about today. And I think I found it very interesting as a generalist because it got me really thinking about how I as a doctor think about language that I use when I frame patient problems. And by addiction, we're not just talking about, say, opioid addiction. We're talking about all kinds of addictions. It could be gambling addiction. Some people think of sex and pornography as becoming addictive for people. Obesity or behaviors towards food, which can become dysfunctional, are thought of as addiction. And so this has broad implications for generalist healthcare professionals like myself. So I'd like to start, Stefan, with just asking you to talk a little bit about what is this debate and why do you think it's an interesting and significant topic?
Yeah, thanks, Saul. That was a really helpful introduction. So the reason it's become intriguing to me is that I think that our definitions influence what questions we ask and what stories we elicit from the people we take care of. So if I think of addiction in some very old school way, maybe 100 years ago, as a deep and profound moral flaw, I guess I don't even know what questions to ask as a doctor. I don't usually assess and interrogate people's morality as a doctor. So I'm left without a way in. If I think about it as a brain disease, it turns out that I wind up asking about what people use and about craving to use. And I start asking, well, what medications can I prescribe to patch this brain that has trouble? And that actually leads to some good outcomes or some potential benefits. In the case of opioid use disorder, that brain hook has the appeal of justifying some of the medications that we can prescribe that seem to be effective. And yet I feel like that leaves a lot off the table and also leaves me without any room. It leaves me without any road to run on when the question becomes, why is my patient not even engaged in the treatments that we think are so effective? So what's going on in a person's life is really important to what goes on with their addiction. And to me, the only way to make sense of what's going on in a person's life is their agency. Maybe it's choice, maybe free will is too loaded, but people are making assessments about what will be rewarding to them in the short term and the long term, and they're responding to those assessments. And if my patient with alcohol use or opioid use disorder or addiction, whatever you want to call it, if they stop treatment or they continue treatment, I need to have a way to interrogate what that is about beyond why are you not taking the medication I prescribe, which is extremely physician-centric. So I have wound up feeling that we need to robustly consider this as a complex disorder with a lot of agency on the part of the person who has the disorder.
Well, now, Nora Volkow, who is the longstanding director of the National Institute on Drug Abuse, or NIDA, which is by far and away the largest funder of research on addiction, apparently in the world, is a strong proponent of the model that addiction is a brain disease. And when I've watched her talk about it, for instance, on YouTube, she often begins by contrasting it with passing a moral judgment on patients and sort of saying, we have to see this as a brain disease because we've grown past the notion that this is some sort of moral failing. And of course, that's when you frame it that way, you're like, of course,
Yes.
this has to be a brain disease if the alternative is that it's a moral failing. On the other hand, one particular proponent of it's not a brain disease model is Mark Lewis. And actually, there's a debate on YouTube you can watch between these two eminent individuals. And Mark Lewis, who's also a neuroscientist, and he is somebody who at an earlier stage in his life struggled with addiction and talks openly about that and has written about it and done a lot of research, says calling it a disease is unhelpful and misses out on a lot of the nuance and in itself is stigmatizing because you're telling patients that this is something that they don't have that much control over. And also you're labeling them as, quote, having this thing. And actually what's interesting is there's some research that shows that among tobacco users, those who think that what they have is a disease have a harder time quitting than those who think what they have is a habit. And so just the way in which we frame this actually affects the likelihood, apparently, that people are going to be able to quit. And so it might be helpful if you could talk a little bit about, at least in simple terms, what is going on in the brain. And I will start by saying that even Nora Volkow says that when you look at the brain of somebody with obesity and somebody with a substance addiction, you see the same thing. So if you could just talk in sort of general terms about what she's referring to.
Yeah. So when we talk about what goes on in the brain, first of all, there are at least two types of circuit that are often discussed. One is a reward circuitry that is triggered by a wide range of things in life, from sex and food to drugs and alcohol. These typically involve dopaminergic circuits that go from what's called the ventral tegmental area to the striatum. That's not essential, but there is a reward circuit, and often that's what's publicized. It's also put forward by George Koob, who's the director of the National Institute on Alcohol Abuse and Alcoholism, that there's also kind of an anti-reward circuit, something that makes you feel a little bit hollowed out when you're not receiving or taking the rewarding substance that you're used to. He devised a word from the old Greek, hyperkatifia, to refer to this lack of reward, a sort of lassitude. And then these circuits, in turn, are connected, of course, across the brain, but can involve the part of your brain that plans and executes actions, which are typically in the frontal lobe, where you decide what it is you want to do. You judge what is worth pursuing, and you go after it. And when I describe it in that way, and it's no doubt that certain drugs really release a lot of dopamine directly. Cocaine, methamphetamines, these release dopamine and cause that reward sensation right away. And the evidence seems to show that other drugs that work through different receptors have many effects across the entire brain, but often indirectly also trigger the same reward circuits, even if they're not directly causing the release of dopamine. So alcohol would be a promiscuous drug. It relates to all, many, many different places in the brain through many different mechanisms. Promiscuous as it is, it's thought to have some effect on dopamine circuits and reward sensations. These are things that go on in the brain. These circuits can be visualized. That's why you would hear Nora Volkow make the case that she makes. I guess the concern that I have is that level of analysis, just because something is happening in a brain, doesn't mean that it's the most useful level of explanation for why a person does what they do.
Yeah, and I think Mark Lewis picks up on that, and others who are challenging the brain disease model, and they'll observe. And Mark Lewis also describes himself as having a kind of neurodevelopmental perspective, which is that the brain is always changing in response to learning, concept of neuroplasticity. And the fact that you see changes in the brain doesn't mean that the person has a disease. Now, what's interesting is addiction is deeply mired in politics in our culture. It is so affected by stigma in terms of how it's framed and thought about. And, some have said, for instance, that for the NIH going to Congress to get huge sums of money to study addiction, it makes for a much better pitch to say, well, this is a brain disease. It frames it. It also is a way of saying, we don't want to stigmatize people. We don't want to say this is your fault. And in that sense, that sounds right too. So that particular way of framing it initially seems very appealing to sort of my take on, as a doctor, of being non-judgmental. But then at a deeper level, you get to the folks who push back on that and say, well, wait a minute. Most people who have addiction actually get over it. It does pass in the vast majority, which is interesting because we as physicians tend to see all of the worst cases. But they're predictable numbers. Apparently, on average, people actually smoking is the
It's
worst.
the
It takes
worst.
20, on average, they smoke for 25 years. But when you get to drugs like alcohol, I think it's more like 15, cocaine, or I can't remember, heroin, those are shorter periods.
5 to 8.
Yeah, 5 to 8 years. So I think that you have to recognize that something in most people is allowing them to get through this. Now, that doesn't mean it's not a disease per se, but what Lewis says is that people with problems who struggle with addictive behaviors often benefit from a variety of interventions that help them modify their behavior. That can include replacing the addiction with something else that perhaps brings meaning into their life. It can involve recognizing that the consequences of the addiction are so brutal that should help them reevaluate the choices they're making. And what's so dicey about that is as soon as you go down that path, others are going to say, okay, now you're blaming people for having addiction. And what Mark Lewis is saying, no, we can't do that. We're not blaming people. What we're saying is that everybody lives and is born into the world with a set of conditions. Those conditions can involve early childhood events that are traumatic. Those can involve conditions of poverty and racism. We recently did an episode called Sonny's Blues where we looked at a story by Baldwin,
Yeah.
where the conditions of life seem to contribute to heroin use in the protagonist, and then he ultimately replaces that with his talent as a musician. So I think what Mark Lewis is saying is we can't fall into the trap of saying it's either or. Either you think it's a brain disease or you're blaming folks for it. You have to recognize that it's something. It's not a brain disease, and that something is tricky because as soon as you assign a term to it, it's voluntary, it's a learned behavior, it's neuroplasticity. As soon as you do that, people can jump on it. So I almost feel like there's a question mark as to what we want to say it is if it's not a brain disease. But I think that from the standpoint of a generalist physician, it's interesting to me because one of the realities of life is that people develop habits to things, that they are habitually doing stuff that's not necessarily good for them. It could be dysfunctional ways in which they interact with their children or their spouses or money or sex or any number of things. And the reasons for that are so multifactorial. And the solutions to those bad habits are so multifactorial. And as a physician, I find that interesting because it captures the richness of life and the necessity of meeting people where they are. And I think Lewis's concern about the brain disease model is it puts people in some kind of a box.
So there's sort of two things to think about. One is when you apply a model, does it imply a judgment? And the second is when you apply a model, does it limit your questions? So if you apply a model of brain disease, historically it was meant to imply that you're not judging the person adversely, but it does imply an assessment that you're dealing with a condition that is uncontrollable and permanent. And that actually fits in a weird way with the sort of old school notion with kind of disease model of alcoholism when it was studied in the 40s, 50s, and 60s by a guy named Jelinek from Yale, sort of this long-term disease that works its way. And occasionally
you mean like
that
the
term
once
disease,
an addict, always an addict concept?
Yeah, absolutely. That you can never free it. The only question is whether you use. It echoes in some ways ideas in the 12-step mutual help movement, except that actually the 12-step movement has been very careful about the use of that word disease. It doesn't consistently embrace it, precisely because it may take away people's ability to change. So the judgment that's implied is permanence. When I say brain disease, particularly brain disease, you might think of Parkinson's disease or schizophrenia. This is an argument brought up by many others, not just me. Sally Satel and Scott Lilienfeld writing in an article in 2014. It kind of implies a thing that progresses over which there is no control.
Yeah, I think a nice contrast would be, say, Alzheimer's. I don't think anyone debates Alzheimer's is a disease. It's not something that we can choose not to have. So I think it's nice to contrast this discussion over is addiction a brain disease with things that we all agree are brain diseases. Parkinson's is a brain disease, and Alzheimer's is a brain disease.
And normally when we apply a term to something, it's because it has explanatory value. That is, the reason I'm going to say brain disease is because it explains a lot. But if we're talking about a condition that remits based on people reassessing their choices, their options, and their opportunities, then the brain disease concept, at least the way we think about those words, doesn't work very well. If a person says, I am now really concerned about my children and about preserving my marriage, I'm going to undertake a process which is going to cause a remission, whether it's taking a medication or going to groups or whatever, The word brain disease now is not explaining how or why the person does that. So in terms of explanatory power, the label's a model. The model isn't always useful. Actually, I'm going to quote a biostatistician I work with. All models are wrong, but some are useful. This model is wrong at times in ways that are distinctly useless, meaning I want to hear a model that helps me account for the young mother who says, now that I have kids, I'm not going to use. I want to hear a model that helps me understand the 42-year-old who relapsed last year, but now realizes that it was really a bad relationship that he needed to get out of. And now he's going to start up taking whatever the buprenorphine that I have made available for the last 10 years. Now it suddenly makes sense. So I don't think it's consistently useful. And I also think that models shape the questions we ask of the people we want to take care of. And that's why it's so relevant for primary care. I work with a lot of medical residents who become enthusiastic about prescribing medications for opioid use disorder. And God knows that is a great thing. We have been a hostile profession to treating addiction. So to have clinicians say, I prescribe a variety of medications for high blood pressure, and with my patients with opioid use disorder, I'm comfortable now offering and starting buprenorphine. That's tremendous progress. And I love it. But those same residents are at a loss when 50% of their patients stop taking the medicine at roughly 6 months, maybe even more than 50%. They say, well, the patient stopped taking. And the question that is sort of ever present in our work together in this podcast and in your book is why? Why did you not continue to take that? And the human storyline about why people start or stop a course of treatment is tied to their assessment of what was available to them long-term in terms of their life rewards or life consequences. And those things usually influence. If you have a sudden crisis and your ex-girlfriend turns up and makes you feel like a terrible person, suddenly the daily buprenorphine that you were taking is no longer very attractive because what you want is oblivion. Or you want to rebond with that girlfriend, and maybe she is actually the person with whom you bond best when you use a mixture of cocaine and heroin. And suddenly your discount curve and your decision matrix totally changes about what you want, and the treatment course is no longer very interesting. So there is a brain activity that's being influenced by the choices a person is making. But those choices, I want us to ask about them. What happened in your life? What is so rewarding to you that you decided to begin treatment? What was so challenging that you let it stop? And right now, opioid use disorder or opioid addiction provides the strongest case for the brain disease model. It's the one where the most utility has become available because of medications. But even with that, even with the very best case scenario, 50% or more of people don't stay on the treatment for over 6 months. A lot of people never want to start it. And we have to have a conversation about those things.
Yeah, I think what this gets at is the question of not just is the model useful, but who is it useful for? Who is it serving and who is it not serving? So I think, for example,
that's good.
The brain disease model probably serves NIH if they're trying to go to Congress and convince them to give them a lot of money because it's a simple construct and it fits with a lot of other diseases we fund. I think the brain disease model works well for what I would call late stage capitalism in the sense that it shifts the blame away from all of the pernicious ways in which our system tries to get people to spend money on stuff, whether it's on highly processed foods, which become addictive. Obviously, the whole opioid epidemic, there was a major unfettered capitalist component to that. So we are all basically swimming in an environment where people are trying to make a buck off of getting us to do anything, good or bad. And that obviously is going to make some of us more vulnerable than others, depending on what kind of protective systems we have in place. If we're socially vulnerable, if we're economically vulnerable, if we've been traumatized in the past, all of this put us at increased risk of falling prey to these money-making operations. But the addiction is disease model works well for continuing that trajectory. Similarly, we have a capitalistic model of healthcare where if you only have 10 minutes with a patient or 15 minutes, you don't really have a process for sitting down to them and saying, well, hey, let's talk a little bit about why you have stopped taking this medication and trying to get them to be self-reflective. You do have time to pull out your prescription pad and write a prescription for, buprenorphine or something like that. And so I think the model is serving usefully certain systems. And I think it's important to sort of ask ourselves, who's benefiting from this model and who's harmed by this model?
I should stipulate that in the case of a medication that has proof of effectiveness in randomized controlled trials, we do want people trained to offer it. We do want to make sure it's part of the fabric of what is on offer. That's the argument I would make, and I think you would agree, is not to say medications are merely a symptom of capitalism, we shouldn't be offering them. Rather, the system we are in is constraining us to limit the dialogue that we have with people and limit the ways we can help them, and ultimately is setting us back. In a way, this really relates to weight and weight control, because we're in this mode right now where a medication we can prescribe, and I'm not saying that I have deduced that all overweight is a condition of addiction. I don't feel expert in that, but we're in a situation where there's a new medication on the market, which everybody is taking to lose weight, and it's quite effective, semaglutide and its various analogs. And this just fits like the world we're in. You can go through a variety of places that will load you up with calories from birth onward, help you gain as much weight as possible. You'll probably work in a place where you sit down and don't walk around very much. And then later on, with the health insurance that you obtain, God willing, from the job that you have, you will buy a medication to help you lose the weight. So you're right that I consider myself a capitalist, but I guess I'm going to say here, capitalism sort of revolves around itself in a way and keeps offering up problems and solutions that are orienting around consumption.
I think what's interesting about the obesity example is, as I mentioned, we live in a society where there's an enormous amount of pressure to get people to eat addictive foods. And that, of course, has led to this problem of obesity. And what is sort of ironic is a solution is actually another way for people to make lots of money, which is this medication. Now, what's interesting and I think somewhat distinct here is that the medication works by taking away people's appetite for the most part. And if you stop eating because you don't want to eat anymore, then that's a great solution because you're not taking in the same number of calories. Now, we may not know what the total long-term effects are of this, but in the short term, it looks like it actually does what it's supposed to, although it also makes a lot of money for other people. But the point is it's a solution. On the other hand, we're not likely to come up with a pill to get people over gambling addiction or porn addiction or any number of these things that's going to have that kind of panacea effect because this one was kind of easy. You just had to get people to not want to eat anymore. I think that the medications like buprenorphine definitely reduce mortality and in that respect are very beneficial.
But they definitely reduce the mortality when you're taking them. The most wonderful paper showing that 50% mortality reduction by Sordo in British Medical Journal /BMJ, whatever you want to call it, it's a comparison of time on medicine to time off medicine in trials. And it turns out during the time that you're on the medicine, your mortality is reduced by 50%. And people quote that as if it's a randomized controlled trial that merely offering buprenorphine or methadone caused a 50% reduction when it's taking buprenorphine or methadone, which caused a 50% reduction, which means that a lot of the question that should be in our mind and in our heart and in our work as clinicians has to be, what led you to think you should take this? Why did you stop? What got you to restart it again? And when we discuss the medications, we're in a system where it can be so hard to prescribe sometimes that all we'll say is there's a 50% reduction of mortality. We really need to provide this. It's super important. But that takes away and takes off the table the fact that human beings are making choices where they're on and off. And this choice is just as important as whether the medication is available.
Absolutely. And I think the key point here is that you're using the word choice.
I've used it about 8 times there.
No, and I think that those questions are essential. You ask people why they decide to do or don't do something. If they decide to stop taking a medication that helps save their life, that becomes a topic for discussion, and the person will have insight about that. And I feel like taking that away from them and saying, well, that's just, that's blaming them or whatever you want to do. I think that's...
They were non-adherent.
I think they're non-adherent. I think in some ways you're diminishing their humanity. And I think that's really what's paradoxical. One thing I think that's interesting about this is that sometimes I ask myself, like, well, what are the politics of this? Like, if I'm a liberal, which side should I be on? And the answer is that doesn't actually work here.
It fits terribly.
It's not, you could say, if you're a liberal and you don't blame people, you should be on the brain disease model. Or no, if you're liberal and progressive, you should be on the, it doesn't work that way. This gets to really deeper insights about the nature of being human. Yeah. And I think that's really what's intriguing. One thing that I wanted to touch on here was a publication of yours and a
Oh,
colleague of
yes.
yours that was a response to another publication that came out in 2023, I believe,
Yes.
called Revise and Refuse Capacity, Autonomy, and Refusal of Care After Opioid Overdose. And it was
Yeah.
written by Marshall and colleagues. And
Yeah.
briefly, I'll just summarize it from my perspective, and then you actually published a rebuttal to it. But what he was saying is, look, if you're an ED physician, emergency department physician, you have countless patients who come in who've been revived by naloxone. And what every emergency department physician is concerned about is that naloxone can wear off before the opioid that got them in trouble in the first place is out of their system. And so if you don't keep an eye on them, they could actually fall back into a state of respiratory depression, which could be lethal. And the issue is that a number of these patients, once they wake up after getting this medication, are like, yeah, I want to leave. I'm done. I'm out of here. And sometimes they're just not that receptive to any effort to keep them in the emergency department. And who knows why they want to leave? Maybe they want to go use again. Maybe they really need to go feed their dog. Who knows? But the point is, oftentimes they just want to leave. And the ethical question is, well, what do we do in that situation? We've tried everything we can to convince them to stay. Our concern is if we let them walk out, the medication they received could wear off, and then they could be back where they started, and they could die from that. And that does happen. And are they in their right mind is really the question. Do they know what's best for them? And remember, this is somebody who's fully awake. And the authors of this concluded, actually, there are circumstances where it really is ethically appropriate to restrain them from leaving because you could save their life. And that really fits the brain disease model. Like they're so affected by this craving and the way this condition has affected their brain that even though they're fully alert, we can't really say that they're adequately decisional. They're not really their full selves. And when I read it initially, I was like, yeah, that kind of makes sense. Sometimes you got to do it. You got to do what you got to do to just keep people safe. But then you and a colleague wrote a rebuttal to that I thought
Yeah.
was really interesting. And I'm wondering if you could share that.
Yeah. So just to recapitulate, the basic arguments that you often see in clinical ethics are something like we want to help people, but if their ability to decide is compromised, sometimes we have to do it against their will. That's a classic clinical ethics argument. And those authors said, look, a person who has addiction, opioid dependence, whatever, their will is compromised in the aftermath of an overdose. And for a few hours, we should be able to hold them against their will. And in the piece that I wrote with my colleague, Kevin Riggs, we didn't actually make a principled argument. We started up with an argument saying, let's just imagine what the outcomes are in a hypothetical randomized controlled trial, randomly assign people to be held against their will for a few hours versus suggesting that they stay, but let them go if not. And obviously this can't be run. This isn't going to happen. But in the randomized hypothetical controlled trial, we deduced that overwhelming survival benefit would likely emerge over the long term on whichever side got most people to come back and decide to take medications that might help with opioid use disorder, precisely for the reasons we mentioned earlier. And we argue that if you hold people against their will, it's likely to lead to a negative feeling, a bit of trauma, a bit of distrust of the healthcare system, and that might reduce their chance of engaging in the kind of treatment that could have a benefit long-term in terms of saving their life. We're talking about medication treatment here. And that respectful conversation, which includes respect for the authority of the individual to leave, even if there is some additional risk in the short term, is likely to be swamped by the long-term risk. And I should acknowledge that when we wrote the article, we agreed in a way that could upset some people that had the trial really been run, and it found the opposite thing, that you really saved a lot of lives by holding people for 3 hours against their will, we were willing to go there and go ahead and do it. But we just didn't think it was very likely. And so that was the basis of our argument. And in the background of my mind was the sense that when you engage people with respect for their power to decide what's going to work for them in the moment, they often remember that. And they often decide that you're worth engaging with again. And as a doctor who's worked for a long time with populations that have been traumatized by the healthcare system, I speak of people who are homeless, but also people with long-term pain, my number one goal is to earn some degree of trust. It's very hard. Even I get people angry at me sometimes. I have to note there's an analogy between the argument that was made in this piece about overdose and a piece written a year or two earlier by a team talking about continuing or stopping opioids in patients with long-term pain. And we actually talked about it probably last year in a piece on suicide and opioids. But the authors argue that the person who's been on opioids long-term for pain has a compromised brain, a compromised autonomy, a state of mental limitation, somewhat analogous to dementia or cognitive loss, and that therefore their self-report on the benefits and the harms of the medication they take can't be fully trusted, and that because they have this compromised volition and compromised understanding, you should decide for them what to do. And lest anybody misunderstand, I am not the candy man. I try to decide what is right, and it takes a lot of time. But I'm very suspicious of arguments that assume that a condition of anything, dependence on a person, dependence on a medication, leads to a person who has no understanding or minimal understanding of what is good for them and what is bad for them. And to cycle back to the post-overdose cases, let's say your patient has just had an overdose and they've just been revived and they're thinking, I want to go use again. Let's admit that's often a reason they want to leave the ED.
Sure.
They may know something about how they're going to find that next dose that you don't know. Like the safest fentanyl dealer, if there is such a thing, is the one who's available between 5 p.m. and 9 p.m. on a certain street corner. And that if they don't get back to that particular dealer, they may have a terrible night in withdrawal, or they're going to have to go to a less safe supply, which might even be more dangerous. So I'm not saying that all people know this. I'm not saying everybody's rational in the world, not me and not my patients, but there is at least a reasonable chance that the person you're interacting with is making some assessment of complicated things that we haven't begun to ask about. So I tend to err on the side of saying, in the long term, what I want is people who are willing to engage with me for care.
Yeah, I think it's unfortunately, the profession of medicine has a very problematic history of taking patients' autonomy away from them by labeling them and saying this person doesn't know what's right. They don't know what's best for them. We need to lock them up. And unfortunately, there's a long pattern of that kind of approach that runs through as a thread in our ignoble history. And I think that the example you give where the well-meaning physician says, we need to physically restrain this patient from walking out, not recognizing that they're thinking about a very short-term issue that's probably, at least statistically, pretty low risk, which is that that person is going to basically go back into a stupor and die of respiratory depression because their antidote wore off before the underlying opioid, that reflects the mental model of the physician, but it also reflects a broader thinking that this patient who is wide awake just doesn't have good judgment, and that my judgment is better than theirs. And I think what you're saying is we need a little humility here. And in fact, when you start to do this hypothetical exercise of a sort of imaginary randomized controlled trial, it actually starts to look kind of different. Like that intervention could cause a major breach in trust, and that when that patient really needs to trust us and where we really can help them, for example, by putting them on buprenorphine, they're not going to come and they're not going to do it and they're not going to stick to it. And that's where there's a real opportunity to save lives. So I think the mental experiment of hypothesizing how things could be different is very useful. I think it certainly made me feel more humble. And when I read it, I was like, oh yeah, maybe that initial argument of we need to protect this person is not necessarily the one that I should jump on. And I think what you're saying is, given all the uncertainty about this, why not just fall back on saying this person is a human being who wants to do what makes sense to them. And so we are not going to make decisions without a partnership. So for instance, if you had a conversation with that patient and said, look, I know you really want to leave. I understand it may be because you're feeling a need to use. Can we talk a little bit about why you want to leave now? Is there something that I'm missing here? And maybe that patient would tell you, yeah, the only drug dealer I can trust is on that street corner for the next 2 hours. I mean, maybe they would tell that to you if they trusted you. And if you thought to ask the question in the first place, and if that was the environment where there was a sort of sense of shared problem solving. And that seems to be what you're getting at. Is that right?
Yeah, and I'm making a bet. I'm making a bet of sorts. First of all, the information you discover might actually be useful. Although, to be fair, I'm not sure that we as a doctor in emergency department can figure out which is the best drug dealer to buy your fentanyl from. So,
no, but
I'm
what you're
making
saying
a
is
bet.
the patient may have an idea.
The patient may know it. I'm making a bet that their ideas might be more rational than you think. And over the long term, it's their ability to reason about what they need to do that probably is what has to be harnessed. I do want to highlight, though, that when people are making choices, they are considering opportunities and consequences. And I don't want to make light of the fact that sometimes the prospective consequences that people consider are important and influence what they decide. So this comes up in the drug legalization and criminalization argument all the time. I don't think it's wrong for there to be consequences even though I'm not particularly fond of our criminal justice response at all. But I don't think it's wrong to say, you know what, people might be making decisions to engage in treatment based on the potential risk long term in light of their competing opportunities. So I'm saying this very, very carefully. Merely the prospect of 10 years in prison for your drug use is probably not the way to approach this, both as a policy matter or as the way that people really think. What they think about is what's available to me on the good side of life if I decide to honor avoiding this consequence. And to give the easiest example, let's talk about a non-addicted person who intermittently used marijuana/cannabis when he was in college. That's Stefan Kertes. So I was not addicted to cannabis. I occasionally used it for parties or whatever. But I was very aware in college that I had a future. I had a future potentially as a doctor. And I kind of remember in second year of college, I used a couple times. It wasn't that great. I wasn't somebody who had a fierce interest. But I thought, oh, this whole cannabis thing, given that we're in the 1980s, this may be a headache later on because of the other rewards that are available to me. And those rewards include certain long-term rewards, like becoming an effective medical student and doctor. I'll let this go. Now, was I comparable to a person with fierce fentanyl addiction living in the Tenderloin of San Francisco? No, I was not. But the idea that I had opportunities, that there was a world I could go forward to, is something we need to be asking about with every person we take care of who might have substance use or substance use disorder, which is in the alternative. If this path of using were to stop, either because of medication or because of a program, what might become available to you that would be motivational? The only conversation you can have is, what do you care about? Who do you care about? What would become available if you were to make this change? And if there's nothing available, if there is no future for a person who stops using, they're probably not going to consistently engage in treatment.
Yeah.
That isn't something we can always fix, but I just wanted to put forward that I'm not against consequences for drug use, but I want us to think about consequences in light of competing opportunities.
Yeah, and I think what follows from that is the importance of engaging with patients to encourage them to self-reflect, to start to think about what is important to me in life and how have I gotten into this situation where I have this particular addiction? What do I see in my future? And these are not rhetorical questions. They're real questions. For some people, taking heroin may actually be the right choice. And I'm putting that in quotes if they're in a situation that feels hopeless and unpromising. Or similarly, if they're affected by past traumas that are kind of monsters that they're struggling with and that this provides them with some relief from, that we have to look at that larger context and consider it and think about where we as healthcare professionals can partner with individuals, recognizing that their addiction may in fact a choice, but one that makes sense for them at that particular time. Now, I recognize that this is dangerous territory because it does move so close to the concept of blaming people. What I've heard listening to people with addiction is that they don't all land on the same page around this issue. Some people have said that seeing it as a brain disease has been helpful to them. It's destigmatized it. It's taken away some of the guilt that they felt, and that model works for them. Many others have said that no, they feel like it doesn't feel like they've been told they have a brain disease, but they don't feel like they have a brain disease. They feel like they've made some choices. And as you know from the neurochemistry, that those choices through a series of feedback loops in the brain get increasingly reinforced and increasingly difficult to break out of because they get entrenched through these cycles of reward and ultimately loss of an ability to inhibit. But I think this, for lack of a better term, psychotherapeutic approach where people are able to kind of self-reflect can sometimes allow them to regain some sense of control, that the inhibitory parts of their brain, that the prefrontal cortex can begin to play an important role in the choices they make going forward. And that's kind of the counter model to the brain disease idea.
I think it's fair game to talk about brain mechanisms as part of the physiological terrain that you're going to have to navigate if you have dependence or substance use disorder, either one. Dependence can't occur without a frank disorder. I mean, it can happen because of the medication we prescribe. But to say, look, this particular substance is salient to you because of all the good times you've had with it and the fact that it's helped you escape bad times. So every time you see a reminder of this substance, it's going to exert some draw on you. That's a reality. That's terrain you have to navigate, just like a mountain. When this substance is taken away acutely, you may have acute withdrawal. The acute withdrawal will be different depending on what substance it is. Again, that's part of the terrain a human being has to navigate. And then finally, when you are off the substance, it could take a while before you feel right because there are some mechanisms in the brain, at least according to George Koob, induce a feeling that's negative, a kind of lassitude and a loss of pleasure that occurs in the absence of the substance due to what he calls a sort of counterforce, an opponent process that makes you feel worse. Those are all brain mechanisms. Those are all brain mechanisms we can discuss. Just as terrain that is now a little bit inbuilt in you that we have to navigate. Just like the other terrain might be whenever you see that ex-girlfriend, it triggers in you a feeling of guilt from which you want to flee. And that's a social terrain that you have to navigate as well. That's part of a recovery process. My hope is that in recognizing the value of kind of open discourse about a person as having agency in all of this, that then we can have conversations which really help them recover and really feel fruitful to us too.
I think the question for those of us who are healthcare professionals is, what's the mental model that we're going to adopt? And I think what's interesting here is, I think we've decided not to label the alternative to the brain disease model. Some people say it's neuroplasticity.
Yeah, we haven't.
Or that it's a learning model. That's one of the terms that Lewis sometimes uses, that it's a form of learning that kind of goes awry. But I think that my preferred option is just not to label it at all, and to say that it captures the ways in which we develop these challenges in our life, represent the complexity of being human, and the way in which our brains are susceptible to so much of what happens to us, that it certainly fits the concept of learning. And that if you think about the way in which the brain develops and changes over time, it integrates the good and the bad. It integrates all of this. And so I think in the purest sense, I might say that's maybe the developmental or learning model is the alternative that would fit for me. But I prefer to say that it's just not a disease model, because I want to take into account all of the stuff that is going on around us, as I talk about, the unfettered capitalism, the way in which we are preyed upon, and the way in which some of us are more vulnerable than others, the way in which it shapes our healthcare system and gives us not enough time to tackle this in a way that is more nuanced than treating it as a brain disease often, and just pulling out our prescription pad. And in the way we're trained as healthcare professionals, often not even to be equipped to have these conversations with patients, not to know how to engage with them, and to talk about why they made the choice to not show up for their buprenorphine, and how that happened, and what's going on, and to create an environment where they're comfortable maybe talking about that, not just to tell us, but also to stimulate self-insight. And so those are things certainly that addiction specialists and counselors can do. But if they have embraced the disease model, then they may not be inclined to do that either. And my understanding is that the brain disease model has been so influential and so pervasive that when you look at addiction programs around the country, most of them have in fact adopted the brain disease model, which could potentially undermine the way in which they think about the relationship with their client and the conversations they have. And that's just a concern I would have.
Yeah, I mean, now I feel like I should defend the disease model, or the brain disease model in particular, just to recognize that if you take care of people with addiction, you often feel marginalized in the profession of medicine and even in other professions. So that one of the reasons why disease conversations are important are specifically to handle the feelings of marginalization that are the result of how badly mainstream health professionals, even medical schools and residency programs, respond to this problem. I read somewhere that in psychiatry residencies, the total mandatory time that must be spent on addiction training is something like 2% of the total time of a psychiatry residency, which you would think would be expert in this issue. So when we have a history of marginalizing something, it is reasonable to look for language that would help us reinsert it into the mainstream. So if the mainstream says we want disease language in a way that has its appeal, and it's not to be minimized, because we have a serious problem with alternatively having seen this as something that has nothing to do with healthcare. And this idea that we need to mainstream addiction within healthcare has a history of about 75 years, from the AMA treating alcoholism as a medical condition to programs and initiatives that arose under Betty Ford, with her leadership and her spurring it forward in organizations that I belong to that are inspired by Betty Ford. So I think we have to acknowledge that. And the other thing we could say is a biomedical brain disease model is quite unique in the claims it makes, but there is an alternative language that's used descriptively by psychiatrists, which is to speak of a disorder. And a disorder is the diagnostic term that you would see right now if you're billing for a visit, and it doesn't require you to impose an in-depth set of assumptions about what's going on. It's just, here's the behavior, this is the phenomenon is causing harm. For purpose of doing research, for purpose of beginning the conversation, we just say the disorder is present, And I think it is a kind of looser terminology that's helpful day to day, and maybe it can help cross this boundary between it has nothing to do with medical care or it has something to do with medical care. It's a disorder.
Yeah, I think that that's just another example of asking the question, who is this model serving and who's benefiting from this model? And I think you're right. The model has not only given legitimacy and some cover to people who
Like
are at
me.
risk of being labeled as morally
Oh, I
failures.
see, like patients, yeah.
I'm talking about on the patient side, but it also gives some street cred to the folks who are in the addiction field. And so it's serving multiple purposes. And it, as I said, it serves people who are trying to get money from Congress. But I think the question, of course, that we're asking is attempting to look at it from the perspective of being a healer, of being somebody who is responsible as a physician or other healthcare professional for the welfare of suffering people. Of people who are suffering, who are our patients, who are struggling, who have unique lives and circumstances. Things have happened to them that they didn't choose, and they have to work with that. And I think one of the things that I think is compelling, Simon used to say this: everybody's doing the best they can with what they have,
Mm,
and that people are just trying to deal. They're trying to deal with the deck of cards that life has dealt them, whether that's the past that they were born into, and whether it's the dismal circumstances that they may perceive lie in front of them, and how they're going to work with the choices that are available, and that engaging them in reflection about that without necessarily even saying, I want you to quit, but saying, well, let's talk about what's going on here, sets the stage for a growth process, a learning process, which may be their path to a better equilibrium state. Because I think we're all sort of in some sort of equilibrium state, which could be in balance with our environment, which may
yeah.
or may not include addictive substances or addictive behaviors.
Yeah.
And we're trying to move people into a place where they will suffer less and where they will, in some cases, do less harm. And to move them is, in a sense, acknowledging that this is going to be a continuation of a learning process, and that is going to come through an acknowledgement of their full humanity and giving them the self-trust, encouraging them to begin to recognize that they can have hope and that they have some control. And that just the belief in that in and of itself may be an important stimulus.
Yeah. What would be better? The questions I ask are, what would be better? What do you think could be better? And if you see nothing, can we imagine possibilities that would be better than where you are now? And ultimately, there's a wonderful chapter in a book. I'll mention this book because it is a good book called Evaluating the Brain Disease Model of Addiction. But there's a chapter.
Yeah, and actually, I'd like to comment on that book because you shared it with me.
Yeah,
It
yeah.
was first published in 2022, and I know one of the authors is your close colleague, Sally Satel.
Yeah.
The book looks, and it's a big book, it looks comprehensively at this debate from multiple perspectives, and I found it very helpful.
It has a collection of essays, both new and old, taking different points of view on the brain disease model. One of the chapters is called Addiction is Not Only in the Brain. And it's rather technical, but essentially establishes the idea that, sure, in the moment of taking a drug or the response to it, what's going on is a brain event. But over the long term, people are responding to an assessment of their lives and what is the likely path of reward that is most available to them, both in terms of the likelihood of it, the time frame on which it's going to be available, and what's possible. And it is a bit technical, but I want to mention it's by Samuel Acuff and J. Lee Tucker, and it presents this notion that people are always still responding in a way like an animal in a cage, not just to the drug that's available, but to the entire environment of possible choices that are available to them over time. This, of course, becomes very important when you get into political disputes about a drug user, say, in a city who seems to have no other opportunities. Because in addition to how you treat, quote, the addiction short term, there has to be a question about, well, what is the life a person has to go back to? Because that's ultimately what's going to play a big role in their decision matrix. So I think these are both clinically relevant issues. I think the way you described it, Saul, is correct, that shared humanity is the basis for a conversation about where people are going. And I think these ultimately resonate to policy as well.
Thanks, Stefan. I think that obviously this debate is going to go on, and I think it's an important debate. I think that our listeners will have their own opinions. For myself, I think that this has been very helpful because I started out initially thinking, oh yeah, it's a brain disease, once I understood what the debate was about in the first place. But then after reflecting more on it, I decided that model serves some useful purposes, but it isn't the best model for me as a clinician. I embrace the science of addiction, of course. I embrace the power of the tools we have, which include some medication interventions for certain addictions. But the model has limits limitations that are inconsistent with the emphasis on engagement, on shared humanity, and on the power of that connection to being a healer that I have found enriches my life as a physician, and that I think is so helpful to people who are struggling and suffering and who come to us for what we have to offer.
Those are the best final words, Saul. Thank you so much.
Thanks, Stefan. We hope you've enjoyed this latest episode of On Becoming a Healer. If you have and you haven't already subscribed, please consider doing so now. Also, please rate us on the Apple Podcast app, as it will help others find us. And if you have a few moments, leave a review. In addition, if you'd like to make a comment about this episode, we'd love to hear from you. There are a couple ways to do that. If you're using the Apple Podcast app, then just open the episode website link and enter your comment there. Or you can directly go to the website contextualizingcare.org, select the podcast tab, and then scroll down and click on the episode. There you'll find the same comment box. Finally, you can always reach us at onbecomingahealer@gmail.com.